So circling back around then to rheumatoid arthritis, one of the conditions that the drugs we've discussed so far are often used to treat. So in treating rheumatoid arthritis, the aim of the treatment strategies is to reduce inflammation and autoimmune attack. This involves treatment options that are just about relieving symptoms like analgesics, like paracetamol and non-steroidal anti-inflammatory drugs. For more severe disease or active flare-ups of the disease, you'd go to corticosteroids to control the inflammation. But for both of these, you don't see any slowing of the progression of the disease, because that's the nature of an autoimmune disease like rheumatoid arthritis. It has a progressive course where you accumulate damage from the inflammation and an autoimmune attack. And very often you get a relapsing and remitting course in particular, where you do have periods of more active disease and then it can go into remission. We have some drugs that aim to try and induce this remission and limit the number of relapses into active disease, and that's these disease-modifying anti-rheumatic drugs. So these work in rheumatoid arthritis and often a number of other autoimmune conditions with inflammatory components as well. So in these, with using these drugs, you want to induce remission, limit relapses, and so limit the accumulated damage from the inflammation and autoimmune attack. So there's actually lots and lots of different disease-modifying anti-rheumatic drugs, a lot of them relatively new as well, and a lot of use of various immunomodulators and things as a disease-modifying anti-rheumatic drug. But we're going to look at just a couple of examples in a bit more detail, some of the older ones. So in using disease-modifying anti-rheumatic drugs, again, the main goal is to induce remission and prevent relapses, so you're intervening before the disease progresses to severe damage of the joints. Now, these drugs tend to have a slow onset of action. They take at least a month and up to 6 months before you might see any evidence of clinical response. And they don't always work for every individual patient. So sometimes people can have to try long, 6-month courses or longer of several different drugs before they find one that works in their disease. And this can be problematic as there's some potential severe side effects. That said, you're looking at trying to avoid some potentially very severe long-term damage. So the risk-benefit analysis often points to their use anyway, despite those side effects. They've all got slightly different properties, slightly different mechanisms of action, or sometimes even very different mechanisms of action, and different toxic effects that then can come with them. So the selection of the right disease-modifying anti-rheumatic drug is often made on a very much patient individualised account, taking into account things like what are the adverse effects and toxicity and how tolerable does that individual consider those to be, what sort of dosing schedules are going to be possible, and what other conditions or age of the patient needs to be taken into account. Now, while they can have severe side effects, the idea with these drugs isn't to take them forever, but to take them to induce a remission, and then maybe take them for a while longer to try and limit the relapse, and then go off them and maybe have to use them again in the future though. So we'll look at methotrexate first. So methotrexate is often referred to as a folic acid antagonist. You know, folic acid is like an essential nutrient. And one of the reasons we need folic acid in the body is we put it through a metabolic pathway, involves some enzymes like dihydrofolate reductase, making it into an intermediate, tetrahydrofolate, and going through several steps that end up with the synthesis of DNA. So you use folate to make building blocks of DNA. And if you use methotrexate, you block one of the enzymes that is involved in this process that ends up with synthesizing DNA. And by blocking this enzyme, you're less able to make DNA. And it's that enzyme in particular because it normally acts on folate, and methotrexate's similar but different to folate, and so it can bind to the enzyme but not get converted, and so it inhibits the enzyme. Now, in making less DNA, you're less able to make new cells in particular, and this is something that methotrexate can do, but it's not actually the mechanism of action of methotrexate in rheumatoid arthritis. It is, however, responsible for some of the side effects of methotrexate in rheumatoid arthritis treatment. And those side effects are basically the same side effects you see in chemotherapy, though much less severe. And in fact, methotrexate is used as a chemotherapy drug, though at much higher doses than its use in rheumatoid arthritis. So those effects are going to be things that come about when you can't make as many cells as you want to. So it's going to affect the rapidly dividing cells of the body. Things like hair follicles causing alopecia, your bone marrow potentially causing low white cell counts and anemia, and gastrointestinal disturbances from damaging the lining. So you get things like nausea and diarrhea. So these are chemotherapy-like adverse effects because it is a chemotherapy drug, but they're less severe because the doses are much lower than for its use as a chemotherapy drug. So that's the mechanism behind the adverse effects, but that doesn't actually explain the mechanism of action in treating rheumatoid arthritis. It's not about preventing, white blood cells from being made. And what they've found is that as you modify the folate pathway, your cells do all sorts of compensatory mechanisms. So this bit of a mess of a chart here is just detailing, it goes detailed here, but it's just detailing how you get changes in the regulation of some building blocks of DNA that end up meaning that you get an extracellular increase in adenosine. Adenosine can be a building block of DNA, but it's also a signaling molecule in the body. And it would normally signal to immune cells to cause immunosuppression. So methotrexate, by disrupting DNA synthesis slightly, then causes cells to compensate in a whole bunch of ways that leads to more adenosine being present outside the cells and acting on receptors to suppress the immune system. And that's the mechanism of inhibiting the autoimmune attack in rheumatoid arthritis. Where it does work, you will usually see some benefits within 3 to 4 weeks, with maximum benefit at about 6 months. And like chemotherapy, it's not something you're taking every day. You usually take it, say, once a week. We'll also discuss gold salts. So this is another alternative disease-modifying anti-rheumatic drug. It's a bit of an older one, and it's a little bit less well understood than methotrexate in terms of its mechanism of action. When we say gold salts, it's not gold metal itself, it's compounds that end up containing gold within them. So it's not just like, scrape off some of your gold ring, it's some actual compounds that just happen to have gold as part of their structure. And these compounds have been able to inhibit a lot of enzyme systems, particularly what we call the self-hydral systems, of ways of activating enzymes. And by inhibiting these self-hydral enzyme activation systems, you suppress things like phagocytic action of macrophages and other leukocytes, other white blood cells. And then you end up having these gold salts accumulate in the joint macrophages, synovial macrophages, and inhibiting their function, particularly in inflamed joints, and so you alter the immune response and get less damage accumulating in those joints. Adverse reactions that can occur though are things like skin reactions, sore, irritated tongue or gums, mouth ulcers, and a potential for an increase in fungal infections as well, because you're inhibiting those immune cells. So these show benefit with a number of cases of disease-modifying anti-rheumatic drugs. It can't be used in certain conditions though, so it's seen to worsen inflammatory bowel disease, even though they're autoimmune conditions too. They actually get worsened by gold salts and can cause problems in patients who have diabetes, heart failure, or renal or hepatic impairment. If you use them in combination with some other disease-modifying anti-rheumatic drugs, like one we're not going into any detail on, penicillamine, you can cause problems with blood cells and get some serious blood dyscrasias, abnormal blood cells and blood cell numbers. You can limit the side effects a little bit and have a better safety profile by using oral preparations, but you do get better efficacy, though more side effects, from injectable forms of the gold salts. Another joint disease where we use some of the drugs we've been talking about in this lecture is gout. And like rheumatoid arthritis, as well as using the drugs we've been talking about, gout also has some further drugs that are indicated specifically for gout and not for other joint diseases. So to understand how these more gout-specific drugs work, we need to understand a little bit about gout, the disease, and particularly how it relates to a waste product of the body, uric acid. So uric acid is a waste product created when we break down purine nucleotides and bases, so that is some DNA and RNA building blocks. And these building blocks could come from our own tissues, so our own tissue nucleotide metabolism, or from dietary sources. And it's a common waste product, and we eliminate it a little bit through the gut and mostly through the kidneys. Now, there are some factors that can lead you to accumulate too much of this waste product in the body, from taking in too many dietary sources of purines. Things like obesity affect your tissue production of purines and uric acid, and a number of things can limit your elimination of uric acid, particularly in the kidneys. So it can be just genetic factors, it can be having metabolic syndrome like hypertension and insulin resistance, hyperlipidemia, any renal impairment, or drugs that can induce some sort of reduction in renal function. So all of those things could cause you to have too much of this waste product, uric acid, in the body. And in a subset of people, for reasons we don't quite understand why it's only a subset, but in a subset of people, that uric acid can become monosodium urate crystals. And these monosodium urate crystals tend to accumulate in the joints. Accumulation of monosodium urate crystals in the joints then leads to inflammation and attacks of sudden, very painful arthritis. And those attacks of sudden painful arthritis caused by monosodium urate crystals is what we call gout. So to treat gout, you want to halt an acute attack as soon as possible. It's a painful and debilitating condition. And then you also want to prevent recurrent attacks, because as well as being painful and debilitating, damage is accumulating in the joints with those attacks. Where you have urate crystals forming in the joints, you often can, or not often, but sometimes can also get uric acid stones forming in the kidneys. Not the most common type of kidney stones, but they can form in the kidneys as well. So you want to prevent that happening too and causing kidney damage. And so overall you want to reduce or prevent disease complications that would eventually result from these sodium urate deposits in the joints and in the kidneys. So you've got to treat the acute attack, but then you're also looking to prevent further attacks from happening and further damage from occurring. And so you need prophylactic treatments often as well. Now in acute attacks, mostly what's used is the drugs that we've already heard about. Corticosteroids, if it's severe enough, often injected either into the joint itself, intra-articularly, or just other parenteral injections, IV and IM and so on, or the non-steroidal anti-inflammatory drugs, particularly the more potent ones like indomethacin, and they usually give good pain relief for an attack of gout. Another option for gout specifically is not just a pain reliever, but this drug colchicine. So colchicine works in gout by limiting the immune and inflammatory response in the joint in response to the crystals. So normally if you had urate crystals in the joint, those would be phagocytosed by cells like neutrophils, and those neutrophils would then phagocytose using changes in their microtubules, and after phagocytosing the crystals, release a whole lot of inflammatory mediators to draw other white blood cells in and set off inflammation. So you get that acute painful inflammation. Colchicine is able to bind to tubulin that makes up microtubules, disrupting the function of these macrophages so they don't really migrate to the area or do their phagocytosis. So in inhibiting the cells, you then inhibit the synthesis and release of inflammatory mediators by them. These are a couple of inflammatory mediators here, a couple of cytokines, leukotrienes and tissue necrosis factor alpha. And you block division of these cells at that site by blocking by the colchicine binding to mitotic spindles, so another use of microtubules in the cells. So by acting on these microtubules, you block a number of aspects of the immune response. So this affects cell division, inhibits the function of leukocytes, inhibits the release of chemotactic factors that call in more leukocytes, and inhibits some other inflammatory mediators as well. So you then limit the inflammation in response to the crystals. Now, the drugs themselves, in terms of their pharmacokinetics, you've got oral administration. They have some enterohepatic recycling, but most of it's eventually lost with the faeces. Those small amounts are renally excreted. So colchicine can be used for prophylaxis, for acute attacks of gout, but more commonly you just use things like non-steroidal anti-inflammatory drugs. If you're getting recurrent attacks though, and they're not just linked to a high purine diet where you can easily just change your diet to stop more gout from happening, where you're getting recurrent attacks, you want to stop those from happening, and where you don't have some simple lifestyle or behavioural modification that can stop the attack from happening, you would then go to a drug treatment to prevent future attacks. So after a first attack, a decision has to be made whether or not to commence prophylactic therapy, and these are therapies that aim to lower the uric acid in the blood, uric acid or urate concentration in the body. So there's going to be several things you'll take into account: how severe was the attack, how often are attacks happening. But if you do go to a prophylactic drug, you'd use one of two groups of drugs, two classes of drugs. The xanthine oxidase inhibitors will look at allopurinol, or a eukosuric drug will look at probenecid. So allopurinol inhibits this enzyme xanthine oxidase, and this is an enzyme that actually makes uric acid. You break down all of these building blocks of DNA, and the last step to create the waste product, the uric acid, is metabolized by this xanthine oxidase. And so you're using a drug that blocks that. You have less uric acid levels in the body, less gout, less crystals that cause gout, and also less crystals in the kidneys causing kidney stones or renal calculi. And so this is done by allopurinol and also its active metabolite, alloxanthine. And most of the effect ends up coming from the alloxanthine because while it's the metabolite, it has a much longer half-life than the allopurinol itself. So you relieve the high serum uric acid levels, that is, you relieve the high hyperuricemia or high uric acid, and then you won't get attacks of gout. Often it's well tolerated, but there can be some pretty severe adverse effects in some cases. So gastric irritation with nausea, vomiting, abdominal pain or diarrhea. Things like cataracts, red irritated eyes, headaches, dizziness, drowsiness and alopecia have also been noted. And rarely but very seriously, what's called Stevens-Johnson syndrome, where you get a whole series of skin lesions and mucous membrane erosions with epidermal necrosis and detachment. So these are some pretty severe side effects. Not common, but very serious when they do occur, because of course you need that skin as a protective barrier. So if that started to occur, or if you didn't tolerate the allopurinol well for other reasons, you might go to a eukosuric. So these work not by preventing the body from making uric acid, but by helping your body to increase its excretion of uric acid, and so lower the uric acid levels in the body and then have less crystals forming in the joints. So they do this by inhibiting tubular reabsorption of uric acid. You filter the uric acid out at the glomerulus, but some of it would usually be reabsorbed in the renal tubules, and you're looking to block that reabsorption so that there's less ending up back in the blood and more leaving with the urine. What was then already deposited in the joints will tend to come out of the joints back into solution. You've got a little bit of a danger of renal stone formation because you're putting more uric acid into the kidney tubules, but that can usually be managed just by making sure you have enough fluid and use urinary alkalizers, things that make your urine a little bit more alkaline, just some basic mineral supplement type things that will then help acidic things to dissolve better in the urine. So you have some adverse drug reactions that can still occur, some gastrointestinal irritation, though that's usually reduced if you have enough fluid intake, and rarely but very dangerously some blood abnormalities, renal impairments or hepatic impairments can occur. So in an acute attack of gout, we usually use the anti-inflammatory drugs we'd earlier discussed, but for an alternative, you can also use this colchicine, which is a bit more gout specific and blocking the immune response to uric acid crystals. And then you've also got the drugs that look to decrease the amount of uric acid in the body, either by stopping you from metabolizing your purines, your DNA building blocks, into uric acid in the first place, by allopurinol doing this, blocking this xanthine oxidase enzyme, so that you don't have hyperuricemia and don't make urate crystals in your joints. Or you can aim to clear more uric acid from the body. In the renal tubules, it would get filtered at the glomerulus, and then some of it would usually be reabsorbed. But drugs like probenecid are eukosurics, and they stop this reabsorption. So for each amount of urine made, you've got more uric acid in it, and you're excreting more uric acid. So that brings us to the end of our lecture for this session. A bit more manageable in size than the last couple of super massive lectures that we've had, but we've still got quite a number of things to remember. So going back over the lecture, you want to concentrate on these 3 points. Looking at the different classes of non-steroidal anti-inflammatory drugs and knowing what the differences are between them, what advantages or disadvantages the different types of non-steroidal anti-inflammatory drugs can have. Most especially though, know the mode of action, the mechanism for aspirin, paracetamol, corticosteroids, gold salts and methotrexate, and the drugs used in acute and prophylactic management of gout, as well as knowing their adverse drug reactions. So those are the points that you want to make some sort of summary notes on going back through today's lecture. But that's all we need to cover then. So I'll see you guys in the next session. Thanks very much.